Sleep in older life is often described as lighter, shorter, more fragmented, but for many older adults, especially those living with dementia, it can become something far more complex, a shifting rhythm that affects memory, mood, and the fabric of daily life. Few have done more to illustrate this landscape than our next speaker. It's a true pleasure to introduce Dr. Sonia Ancoli Israel, Professor Emeritus of Psychiatry at UC San Diego, whose pioneering work has helped us understand how sleep and circadian rhythms evolve with aging and how we can better support patients and caregivers through those transitions. Her work has brought clarity to an area that is often challenging and deeply human. We're truly honored to have her here with us today, and please help me extend a warm welcome to Dr. Sonia Ancoli Israel.
Thank you, Alon. It's my honor to be here and to speak to all of you about sleep and aging. It's been one of my areas of study for about 45 years, and I've gotten older myself, so I appreciate it all even more now. I have nothing to disclose. I've been retired for 13 years now, so not doing much consulting anymore. So my objectives for you for this lecture are that you'll be able to identify changes in sleep architecture that occur with aging, understand what the consequences of poor sleep are, identify the comorbidities that are often associated with poor sleep in older adults. We'll talk about some of the primary sleep disorders that are quite common in this population and their treatment. We're going to talk quite a bit about the association between sleep apnea and cognition and dementia, and then in general, the relationship between sleep and circadian rhythms and dementia. So I always like to start with this cartoon. This is Marvin. Marvin's playing a game, doing a puzzle with his grandpa, and his grandpa falls asleep, and Marvin thinks, Grandpa's asleep playing with me. I better put these someplace for safekeeping, and he takes Grandpa's glasses. And obviously, it's not the glasses that I find funny here. What's important to me here is the fact that Grandpa fell asleep while playing a game with his grandson. And if you don't remember anything else from this talk, remember this. This behavior, this falling asleep at inappropriate times, is never normal behavior, no matter how old the individual is. So what we're going to talk about today is what are some of the reasons that Grandpa is falling asleep in the middle of the day. So there is this myth out there that as we get older, we need less sleep. These are data, they're a little old now, but still data from the National Sleep Foundation, whose mission, as I'm sure you know it is to educate the public about sleep. And every year they do a survey. And this is a survey, this is actually a combination of two surveys they did with how many hours of sleep different age groups reported. So blue is age 18 to 54. The purplish pink is 55 to 64. The yellow is 65 to 84. And the orange is the combined 55 to 84. Unfortunately, they defined older adults starting at age 55. Even back then, I argued with them that that was too young, but I lost that battle. So we have this one survey, which was 55 to 84, and a previous survey of 18 to 54. And what you see here is that during the week, the younger adults report sleeping just under 7 hours a night, but on average, older adults report 7 hours. On the weekends, the older adults are still at 7 hours. The younger adults are sleeping much more. They're trying to make up for the sleep deprivation that they had during the week. But the point is that older adults are sleeping about 7 hours. Their sleep is not reduced just because they're older. There was this wonderful meta-analysis that was done looking at sleep over the age range, over 3,500 subjects aged 5 to 102. And what they found from this meta-analysis was that the major sleep changes occur actually earlier in life, in the earlier and mid years. And in healthy older adults, sleep was pretty constant from age 60 to the mid 90s, except for sleep efficiency, which decreased. And I'll define that and go over that for you to show you what that looked like in a minute. But here's slow wave sleep. And people have said for years that as we get older, we lose our slow wave sleep. But what you see here is, in fact, is it starts decreasing in our 30s, and then it stays pretty stable. So yes, it is reduced, but it's not just in older adults. Sleep efficiency, however, does change. We have men in blue and women in this pinkish purple color. And you can see with age, sleep efficiency does decrease. You probably know what sleep efficiency is, but just to make sure we're all on the same page, sleep efficiency is the amount of time you're asleep given the amount of time that you're in bed. So in the ideal world, you would be asleep the entire time you're in bed. But it takes a little bit of time to fall asleep. Everybody wakes up once or twice during the night. So we consider good sleep efficiency to be 90% or above. And you can see with age in both men and women, this does decrease. So the question is why? Why is sleep efficiency decreasing in these older adults? But let's look first at some of the associations of poor sleep in older adults. So these are data from the Mr. Oz study. This was a very large study of older men. I'll also show you some data some point during this talk from the SOFT study, which was a sort of sister study in older women. These were two very large epidemiological studies. So these data on this slide are from over 3,000 older men looking at depression and sleep. And what you see is for those who had poor sleep quality on the Pittsburgh Sleep Quality Index, they had twice the risk of having depressive symptoms and 3.5 times the risk of actually having diagnosable depression. And if they took more than 1 hour to fall asleep, and this is based on actigraphy, it was also about 1.5 times the risk of depressive symptoms and about the same for depression. So poor sleep in older adults is associated and does increase the risk of depressive symptoms and depression. So there are consequences. What about physical function? Physical function here is defined as being able to get up out of a chair without any help, or being able to walk down a narrow walk, which is looking at balance in part. And what we see here is having a low sleep efficiency, less than 80%, almost 2 times the risk of being unable to get up out of a chair, and 1.3 times the inability to walk down a narrow pathway. And if they were awake for more than 90 minutes during the night, again, 1.7 times the risk of having a harder time getting out of a chair, and about the same as the poor sleep efficiency for walking down the narrow pathway. So now we have sleep disturbances associated with both depression and with physical function. There were other things that we looked at in these studies. We found that there was a 30 to 40% increased risk of falls associated in women. This is from the women's study, of sleeping less than 7 hours a night or having a sleep efficiency less than 65%. And I'm sure you know that the consequences of falls in the older adult can be quite serious, often leading to death. And even separate from the falls, there was an increased mortality risk in these older women, with those that slept less than 5 hours a night, a sleep efficiency less than 65%, or taking long naps over 2 hours during the day. So having poor sleep can have very serious consequences in the older adult. The other consequences include difficulty with attention, a slower response time. And when I talk about response time here, I'm not talking about how long does it take them to push a button in response to a stimulus. It's how fast can they slam on the brakes if a child is running in front of their car. That's response time. And that is slower with disturbed sleep. Difficulties with memory, decreased performance, and we already talked about depression, physical function. Cognitive impairment we haven't talked about. We're going to talk about that quite a bit later on. Falls and mortality. Now, if a patient came in to see you with these symptoms, one of the first things you are likely to think about is that this may actually be dementia. And it may be, but it may also just be disturbed sleep. So it's very important to remember these risk factors that are associated with disturbed sleep. So why does sleep deteriorate as we get older? Does it get worse? Is it just aging? Is it just because we're getting older? No, it's not. Aging on its own does not cause sleep problems. But all the things that happen to us as we get older do cause sleep problems. And those are the things we're going to talk about now, all the things that go wrong as we get older. So the factors that affect the ability to sleep in the older adult include medical and psychiatric illnesses, all the medications, the polypharmacy that older adults take, changes in circadian rhythms, and primary sleep disorders. These 4 disorders are quite common in the older adult: insomnia, sleep apnea, REM behavior disorder, and restless legs, periodic limb movements. I'm going to focus on the insomnia and the apnea. I'm sure knowing the wonderful lectures you've had today, you've already learned all about REM behavior disorder and restless legs. So I'm not going to spend time on those, but if there are questions, I can always answer those later on. So let's start with medical conditions. Pretty much anything that causes discomfort is going to be comorbid with disturbed sleep. And notice I say comorbid. It's not that the medical illness is resulting, is primary and the sleep is secondary to the medical disorder. These are comorbid, and that has implications for how they're treated. That means they need to be treated simultaneously. If you treat just one or just the other, you're not going to get a full response. And the type of medical conditions that are associated, that are comorbid with poor sleep, include pain, whether it's from headaches or arthritis or cancer, neuropathy, the neurodegenerative processes certainly, which again we'll talk about, COPD, GI changes, nocturia, having to get up to pee 2 or more times during the night. That's certainly going to disturb sleep. So if someone has these medical conditions, and if you think about your older patients, I'm sure you can imagine and you can remember that most of them don't have just 1 or 2 of these, they have many of these. And the key is to treat these and the sleep at the same time. These are also data from the National Sleep Foundation, and this time we're looking at sleep problems and how many medical conditions the older adults had. And here the blue is no medical conditions, the pink is 1, the yellow is 2 or 3 medical conditions, and the orange is 4 or more. And you can see that whether they're sleeping less than 6 hours, especially with 4 or more medical conditions, many more high percentage of older adults report sleeping less than 6 hours. Having any insomnia, all the areas have it, but especially 4 or more conditions, and excessive daytime sleepiness again. So if your patients have multiple medical conditions, there's a high likelihood that they're also having difficulty with sleep. So this is one of the reasons why older adults have a harder time getting the sleep that they need. So remember I said the need for sleep isn't changing, but the ability to sleep, the ability to get the sleep that they need is changing. And one of the reasons are these medical and psychiatric conditions. Another reason is polypharmacy. So here's Marvin again. He's sitting with his cousin, I guess, and he says to her, how come Grandpa never goes to a job like other big people? Because he works at home, silly. See, he runs a drugstore. And certainly our older adults take multiple medications. And these are also big contributors to poor sleep or associated with poor sleep. So this is a short list. Alcohol certainly not prescription, but many adults, older adults, use alcohol to help them fall asleep. As you probably know, alcohol may make you sleepy initially, but many hours later, when it leaves your bloodstream, it wakes you right back up again. So if you drink a lot with dinner, you might be sleepy right after dinner, but by the time you're ready to go to bed, you're going to be wide awake. Or if you drink some alcohol right before bed to help you fall asleep, you will fall asleep faster. But 1, 2 in the morning, you're going to wake up again. So alcohol certainly is associated with insomnia. Caffeine, I used to tell patients no caffeine after lunch because caffeine has a long half-life. And caffeine, of course, is not just sodas. Many substances have caffeine in them. My patients used to say, oh, I don't have any caffeine. I just drink green tea. Green tea is loaded with caffeine. And diet sodas, by the way, have more caffeine than the non-diet equivalent. So that's something to keep in mind. Nicotine, in case they need another reason to stop smoking. But let's look at the prescription medications: antidepressants, corticosteroids, decongestants, beta agonists and antagonists, statins, which just about every older adult takes, stimulants, dopamine agonists, all of these are known to be associated with poor sleep. And one of the things that we can do is take those drugs that are more sedating and have the patients take them at night, take the drugs that are more activating, have the patients take them in the morning. And just by adjusting the dose, lowest possible dose, and the time of day of the medications, you can have a tremendous positive effect on that patient's sleep. So that's the second reason that older adults have a harder time getting the sleep that they need. The next reason are changes in circadian rhythms. Ben Franklin was wise enough to say early to bed, early to rise. I don't think he knew he was talking about what happens to sleep in older adults, but that's exactly what happens. This picture was from a magazine that I cut out, but I thought this is the epitome of what happens to older adults when they go to the opera or the movies or the theater or just home watching TV. We fall asleep. So let's look for a moment at what happens to circadian rhythms with age. The typical phase for the younger middle-aged adult is they get sleepy maybe at 10, 11 o'clock at night. They go to bed at that hour. That's when core body temperature drops. They go to sleep, and about 7, 8 hours later, core body temperature rises, and that's when they wake up. And that is your typical phase. And of course, I say about 7, 8 hours because that is the recommended amount of sleep for adults and for older adults. Older adults also need 7 to 8 hours of sleep. So at different times in our life, these circadian patterns shift. So teenagers, young adults have what we call a delayed sleep phase. They don't get sleepy till maybe 1, 2 in the morning. And once they go to sleep, they actually need 9 to 10 hours of sleep. So if you do the math, they're waking up way late in the morning hours. And as parents of teenagers, we would yell at our kids, right? Stop being so lazy, stop sleeping the whole day away. But this is a very normal pattern for them to go to sleep late and wake up late. That's why early school start times have always been a problem. For them to go to sleep, to go to school at 6, 7, 7:30 in the morning is like the rest of us trying to sit in a math class at 3 in the morning. It's really hard. And it also explains why high school kids often and college kids often sleep during their first 2 classes at school. But so this is a delayed sleep phase. Most adults outgrow this as they grow into adulthood. This advances or shifts back to the typical phase. But there are many adults who stay delayed their whole life. We call them our owls. If you're an owl, you know you're an owl. But as I say, for most people, it shifts. But as we continue to get older, the pattern continues to shift or to advance. So older adults have an advanced sleep phase. We, and I have to say we because this has now happened to me too, we get sleepy at maybe 8:30, 9, 9:30 in the evening. If we went to sleep then, we would sleep our full 7 to 8 hours. But if you do the math, that means we're waking up at 4 or 5 in the morning, which is exactly what I'm doing these days. But what older adults think is they say, oh, why am I waking up so early? I must have insomnia. Here are 2 scenarios of things that happen. The first scenario is they think that even though they may be sleepy at 9, 9:30, they think, oh, that's too early to go to bed. So they sort of make themselves stay up till 10 or 10:30, but they're still waking up at 4 or 5 in the morning. Now they're not in bed long enough to get a full night's sleep. So they might nap sometime in the afternoon. That nap allows them to stay alert later into the evening, but they're still waking up at 5 in the morning. So they get into the cycle of not sleeping enough at night and needing to nap during the day. The more common scenario is they have dinner early, they sit down to watch TV or to read, and they fall asleep. And they'll sleep for maybe half an hour, an hour. Then they wake up, they go to bed, and now they can't fall asleep because they've just slept. Remember, sleep is part of this homeostatic process. You have to be awake a certain amount of time before you're sleepy enough to fall asleep. And they haven't been awake long enough. So now they have trouble falling asleep, and they still wake up at 5 in the morning, and they come in to see us or their doctor, and they say, Doc, I have horrible insomnia. I have trouble falling asleep. I have trouble staying asleep. But it's not insomnia. It's advanced sleep phase in combination with some very poor habits. That is this napping or sleeping in front of the TV. And by the way, I would ask my patients, do you nap in the evening? And they go, oh, no, because they don't consider sleeping in front of the TV as a nap. Now, there are ways to deal with these changes in our circadian phase. For people with delayed sleep phase, the best treatment is morning light. Light is the strongest cue that our rhythms have to shift and also to be strong. So morning light strengthens our rhythms. It also helps our sleep, and that's the best approach. So half an hour outside without sunglasses. The key is no sunglasses, because the mechanism of the light is through the eyes, through the suprachiasmatic nucleus, which is where our main clock, our main pacemaker resides. So morning light is the best way to advance this rhythm. We also sometimes use very low dose melatonin, 0.25 or 0.5. So you actually have to buy like a 1 milligram and cut it in half. But you're not taking it at bedtime. You're not using it as a sleeping pill. You're using it to advance the rhythm. So you take it at about 3-4 hours before your bedtime. First time you take it, make sure you're home, so that make sure you don't get sleepy, but you probably won't, because I say it's not a very good sleeping pill. So that's how we treat or advance a delayed sleep phase. For people with advanced sleep phase, older adults, we use evening light. I put a light bulb because the sun isn't always out in the evening, so you could do very bright light in the evening, whether from light visors, light glasses, or actual light box. But really what I would tell our patients is go out as late in the day as possible while the sun is still out. Take your walk then, again without sunglasses, and get your late afternoon, early evening nap. We would never give melatonin to someone with advanced sleep phase, because you would have to give it in the morning. And even though, as I said, it's a lousy sleeping pill, it might make them a little sleepy, so you never take it in the morning. So now we have 3 reasons why older adults have a harder time getting the sleep that they need: the medical and psychiatric problems, polypharmacy, and normal changes in circadian rhythms. So now let's look at some of the primary sleep disorders. We'll start with insomnia. I'm not going to define it for you. You've had lectures on insomnia, but we're going to talk more about prevalence and consequences in the older adult. So these data are at almost 10,000 elderly people, and about half had a chronic sleep complaint. More than half had a chronic sleep complaint. 30% had a complaint that wasn't chronic, and only 12% had no sleep complaints. But what was very interesting about this 57% is that these disturbances were primarily associated with poor health. So again, it's all those medical issues that older adults have that are associated with poor sleep. And when Foley and colleague followed 2,000 of these older adults who had chronic insomnia, at follow-up, which was 2 years later, 50% had no more symptoms of insomnia. And the improved sleep was associated with improved health. And Foley's conclusion, and this is really important, is that these data do not support a model of incident insomnia caused by the aging process per se. As I said, it is not aging that's contributing to poor sleep. It's all those other things that happen to us as we get older that make it harder for us to get the sleep that we need. The other sleep disorder I want to focus on is sleep apnea, sleep disordered breathing. So this photograph on the left is of Brahms, the composer, ironically, of Brahms' Lullaby. This is a photograph I took many, many years ago in Vienna, a statue of Brahms. And I looked at this statue and I thought, Brahms had sleep apnea. Look at him. First of all, he's overweight, risk factor. He's older, that's a risk factor. He likely has a thick neck under this beard, that's a risk factor. And he's fast asleep. Who has a statue made of them fast asleep, napping during the day? So clearly this was a problem that he had. And I'm pretty sure he had sleep apnea. The other symptom, of course, is loud snoring. You've had lectures about apnea. You know how loud the snoring is. I used to have patients who told me their neighbors across the alley could hear them snoring. And even though it's the man snoring here, us women do snore as well. And we also, of course, have sleep apnea. So what is the prevalence of sleep apnea in the older adults? One of the earliest studies was out of my laboratory, late 80s, early 90s, showing that about 62% of older adults, this was age 65 and older, had a respiratory disturbance index of 10 or more. So more than half of these older adults, these were randomly selected older adults, had what we would consider substantial sleep apnea. In the larger Mr. Oz study, my study was a little over 400. This is 2,900. They found that 26% had RDI greater than 15 and 60% had an RDI greater than 5. And the prevalence of an RDI greater than 15 increased with every increasing quartile of age. The prevalence of RDI greater than 5 did not increase with every quartile. So it was just the more severe apnea that did. And in a more recent large study of community recruited adults, they found that for those aged 60 to 85, almost 50% had an RDI greater than 15, and you can see the breakdown, 65% in men, 35% in women. And this was significantly higher than in younger adults, clearly. And I want to point out about the women, the prevalence in women especially goes way up with menopause. So women who are postmenopausal have a much higher prevalence of sleep apnea. So that estrogen was clearly protective. So one question is why? Why is sleep apnea so much more common in the older adult than in the younger adult? And this is a very elegant study done by my colleague who I believe spoke with you today, Atul Malhotra. He did the study when he was still back at Harvard. And he did MRI of older adults looking at their airway. These are not patients with sleep apnea. This is just looking at their airway. And he found that the soft palate is longer, the pharyngeal fat pads increase in size, the shape of the bony structures around the pharyngeal airway change, and the response of the genuglossal muscle to negative pressure stimulation diminishes. And all these things would, in fact, contribute to sleep apnea. So the question one has to ask, since it's so common in the older adult, is it pathological? Most studies suggest that apnea in the older adult does not increase the risk of mortality, while it might in the younger adult. Nevertheless, we do know that in older adults with apnea, they are excessively sleepy, and that the apnea contributes to decreased quality of life, greater risk of nocturia, hypertension and cardiovascular disease, and decreased cognitive function. So let's talk some about the relationship between apnea and cognition. This is a study, this was a cross-sectional study of older women, 400 of them. You can see the mean age was almost 83. And Adam Spira and his colleagues found that the apnea was associated with cognitive impairment as measured by the MMSE. For those with a AHI greater or equal to 15, the risk ratio of being cognitively impaired was 1.5 times. If they had an AHI greater or equal to 30, it was 3.4 times the risk of being cognitively impaired. And if their oxygen saturation dropped below 80%, it was about 3 times the risk of being cognitively impaired. And each standard deviation increase in the AHI was associated with a 70% greater odds of cognitive impairment. So this really supported the idea that having sleep apnea is increases the risk of developing dementia. This is a study that I was involved in with Christine Yaffe and the Mr. Oss and SOF studies. Here we were looking at older women. It's a SOF studies. We compared women with apnea and without apnea and followed them. And at a 5-year follow-up, those who had apnea were significantly more likely to have developed either mild cognitive impairment, MCI, or dementia. 31% versus 45% with an adjusted ratio of almost 2 times the risk of developing dementia or MCI. Having an elevated SaO2 that is desaturating more than 15 times an hour, and having spending a high percent of the night with having apneas or hypopneas was also associated with the risk of developing either MCI, almost twice the risk, 1.7, or dementia, which is twice the risk. What was interesting in this study is measures of sleep fragmentation or sleep duration were not associated with greater risk of developing cognitive impairment. It was just those factors associated with apnea, with breathing. So since then, there have been a lot of studies looking at the relationship between apnea and biomarkers of Alzheimer's disease. I don't expect you to read this slide. The point of this slide is just to show you how many studies have been done, and I think at this point there are probably many more. Lots of people have looked at this association. And these are data just from one of them. This was the Baltimore Longitudinal Study of Aging, where they did neuroimaging. This was a pilot study, so they had 13 older adults, 8 with normal cognition and 5 with mild cognitive impairment. And they showed that for those adults with mild cognitive impairment, having a higher apnea-hypopnea index and a higher oxygen desaturation index was associated with a greater beta-amyloid deposition. There were no significant associations between apnea and beta-amyloid among the cognitively normal participants, and there was no significant association between sleep duration or sleep fragmentation with beta-amyloid deposition, similar to the results in the YAFI study. And what Spira and colleagues concluded was that these results suggest that among older adults with mild cognitive impairment, greater apnea severity is associated with greater beta-amyloid deposition. This was another study done looking at beta-amyloid and apnea. Here they were doing PET studies, looking at cognitively normal adults with and without apnea. And they concluded that the apnea accelerated the amyloid deposition and might contribute to the development and or the progression of Alzheimer's disease. So these are definitely related. We looked many years ago at the relationship between sleep apnea and dementia in a nursing home population. And what we found was that 90% of the patients in the nursing home, 90%, that's just about everybody, had at least an AHI, an apnea-hypopnea index of 5 or more, with a mean AHI of 32. It was not mild. 63% of the patients had an AHI greater or equal to 15, with a mean of 41. 50%, half of them, had an AHI greater than or equal to 20, with a mean AHI of almost 47. So the apnea was quite prevalent and quite severe in this population. By the way, I don't know how many of you recognize this. This is a very old Medilog recorder. It was an analog recorder. It actually had a tape cassette in here, which recorded the respiration and wrist movement. And we also did leg movements to look at parallel limb movement. So very old technology. You can see an actigraph here, but it was actually attached. It was analog, not digital, and attached to this tape recorder. Anyway, for those with more severe dementia had more severe apnea, and those with more severe apnea had more severe dementia. They were most definitely associated with each other. So the question then becomes, if you treat sleep apnea in the older adult, will that lead to improvement? And in a review of the literature, Weaver and Chasson concluded that treating sleep apnea in the older adult certainly reduces or eliminates the apneas. It improves sleep architecture, daytime sleepiness, self-reported symptoms of snoring and gasping, motor speed and nonverbal learning and memory improve, vascular resistance, platelet coagulability, and other factors affecting cardiac function are improved. And it has a positive effect on nocturia, so that patients are not getting up as often during the night to go to the bathroom. We, however, wanted to look at the effect of treating sleep apnea in patients with Alzheimer's disease. So we moved out of the nursing home into the community. We recruited patients with mild to moderate dementia living at home and with sleep apnea, which we diagnosed. And we had two groups. We had a group that had 3 weeks of 3 weeks of sleep apnea followed by 3 weeks of CPAP, followed by another 3 weeks of CPAP, and another group that had 3 weeks of placebo, which was a mask that had holes in it, so they never actually got any real pressure. We called it crap. So they had 3 weeks of the sham CPAP and then 3 weeks of real CPAP. And if you look at the results of AHI, here's baseline. So here's where the first group was at baseline. This is just looking at the this is the full 6 weeks. Sorry. So here's baseline. AHI of 30. After 3 weeks of treatment, it was down to pretty much normal levels, and the following 3 weeks as well. In the placebo group, they continue to have sleep apnea. This is not a significant increase, although it looks like it. But as soon as they went on real CPAP, it reduced to normal levels. Same thing, significant improvements in the Epworth sleepiness scale, so they were less sleepy with real CPAP. But when we looked at the combined 3 weeks of treatment, the first 3 weeks in the CPAP group and the last 3 weeks in the placebo CPAP group, we found that, of course, as I said, the AHI levels improved, oxygenation improved, Epworth improved, but sleep improved. They had less N1, they had increased amounts of N2 and REM sleep, less WASO and less arousals, and they showed improved cognitive functioning. We didn't cure Alzheimer's disease here, but I think that when your Alzheimer's is a certain level and you have sleep apnea on top of it, it just makes it worse. But when you treat the sleep apnea, it brings the dementia levels back down to their baseline levels. What was also very interesting is that some of the caregivers of the patients really liked what they saw in the Alzheimer's patients who were being treated, and they asked if they could keep the CPAP machine. And we followed them for 6 months, and as well as following some that did not continue. And we found that those that continued using CPAP had a slower progression of their dementia. Again, we're not curing it, but the slope improved. So they weren't progressing in their dementia as fast as those that did not get treated. So again, this is a slide that a table I don't expect you to read, but to show how many different studies have looked at the effect of treating apnea on cognition. I think we were the only ones to do it in dementia. These are studies in non-demented adults. But again, what they concluded was CPAP may be effective in improving cognition, particularly in the presence of sleepiness and given good treatment adherence. In our study, the demented patients used their CPAP for an average of 4 hours, which is not that different than many clinic patients. The CPAP treatment also showed promise for delaying further cognitive decline, and more cognitive assessments were encoded and recall were separated by a period of sleep or needed to understand the relationship between apnea and impaired cognition in these adults. So when do you treat sleep apnea in the older adult? By the way, this is one of our patients from our study wearing his CPAP. The bottom line is that if sleep apnea is associated with clinical symptoms, then it should be treated regardless of the age of the patient. If they have excessive daytime sleepiness, hypertension, cognitive dysfunction, nocturia, cardiac disease, or high levels of sleep disorder breathing, they should be treated no matter what the age of that individual. I just want to very quickly, even though I'm not speaking about periodic limb movements and you had a full lecture on that, there are several studies showing that PLMS is also associated with poor cognition and dementia. Again, a study from, I believe this is the Mr. Oz, older men, Mr. Oz study, over 2,600 older men without dementia, but with PLMS were followed for 3.5 years. And the higher the PLMS was, the greater the cognitive decline during that time, particularly in executive function. And those who had a more severe PLMI were 48% more likely to experience the development of significant cognitive impairment. In a more recent retrospective study based on inpatient medical records of both middle-aged and older adults, they found that having a PLMS greater than 5 was associated with poor cognitive function. And this was partially mediated by REM sleep duration and the arousals related to the periodic limb movements. So it's not only apnea that's related with cognition, but periodic limb movements and sleep may also be related to cognition. So let's talk about general sleep, not sleep disorders, but general sleep and cognitive function and dementia. So this is an old quote from Ronald Peterson. Is it that your sleep is disturbed and the Alzheimer proteins build up? Or are the Alzheimer's proteins being deposited in the brain, disrupting sleep, and that's where the cycle gets initiated? Well, this is a real chicken and egg problem. We don't know. And in fact, I think it's actually bidirectional. So let's look first at what sleep-wake disturbance does to neurodegenerative disease. So in this study, they looked at the association of sleep duration in both middle age and old age, looking at the incidence of dementia of close to 8,000 adults with a 25-year follow-up. And they found that higher dementia risk was associated with a sleep duration of 6 hours of less compared to a normal 7-hour sleep duration. Persistent short sleep duration was compared to persistent normal sleep, and that was also associated with a 30% increased risk of dementia. And that was independent of all the things that one controls for. So they concluded that short sleep duration is associated with an increased risk of late onset dementia. So it's not just the sleep disorders, but it's poor sleep or short sleep as well. These are studies, this is a study in older women in the SOFT study, close to 3,000 of them. And here we're looking at poor sleep efficiency, less than 70%. There was 1.6 times the risk at follow-up of being cognitively impaired, whether on the MMSE or close to 2 times on the TRAILS-B. Taking 30 minutes or longer to fall asleep was associated with cognitive impairment, and being awake 30 minutes or more during the night was also associated with a greater risk of cognitive impairment. So that again speaks to that idea of poor and disturbed sleep, even without having a sleep disorder, increases the risk of cognitive dysfunction. And there's also, we now know, an association between sleep and beta-amyloid and tau deposition. In cognitively normal adults who were followed for 3 years, there was worse sleep efficiency and more frequent napping associated with beta-amyloid deposition. And you see that here in this plot, sleep efficiency less than 75%, 75 to 89 and greater than 89, and much more beta-amyloid deposition with poor sleep efficiency. And you can see that here as well. In the Baltimore longitudinal study of aging, those who had excessive daytime sleepiness were 3 times as likely of having positive beta-amyloid 16 years later follow-up. And if they reported short sleep and lower sleep quality, that was also associated with a greater beta-amyloid deposition. In another study in cognitively normal elderly, reduced and fragmented slow-wave sleep was associated with increases in beta-amyloid in the CSF, suggesting that disturbed sleep might drive an increase in soluble brain beta-amyloid prior to the amyloid deposition. And 1 night of sleep deprivation resulted in a significant increase in beta-amyloid in brain regions that have been implicated in Alzheimer's disease, and this has been shown both in rodents and in humans. We now know or believe that slow-wave sleep helps clear the beta-amyloid and the tau from the brain. So if you have decreased slow-wave sleep, it's not, your brain's not getting cleared out, and that might then increase that risk of depression. So what we know about sleep and beta-amyloid, we know extracellular levels of beta-amyloid and tau fluctuate during the normal sleep-wake cycle. Disturbed sleep and increased wakefulness acutely lead to increased beta-amyloid production and decreased clearance, and beta-amyloid aggregation and deposition is enhanced by chronic wakefulness in animal models. Again, they're not getting their slow-wave sleep. Once the beta-amyloid accumulates, there's evidence in both mice and humans that this results in disturbed sleep, and acute sleep deprivation increases levels of tau in the mouse brain and in humans. So again, we need that slow-wave sleep. And chronic sleep deprivation accelerates the spread of tau protein aggregates in neural networks. So there is a very strong connection that we now believe between poor sleep, beta-amyloid, and tau. And of course, the beta-amyloid and tau are associated with dementia. And then you have the accumulation of tau aggregates in the brain correlated with decreased non-REM sleep, that is the slow-wave activity. And you see that here in this plot as well. So what about if we look at the other way around? What does neurodegenerative disease do to sleep-wake disturbance? This is a photograph that I cut out of the Time magazine, but for all the years that I did research in the nursing home, this is just what it looked like. Patients would sit in the hallway, sound asleep much of the day So what do we know about sleep and Alzheimer's disease and dementia? Well, basically, we see an exaggeration of the normal age-related changes: shorter, more fragmented sleep, lower sleep efficiency, reduced slow-wave sleep and REM, and greater dementia severity linked to greater sleep fragmentation. What are the mechanisms that might be contributing to this? Well, the first is the loss of brain volume in the suprachiasmatic nucleus. So this is a study that was done by Schwab, looking at the number of cells in the suprachiasmatic nucleus, which is where our pacemaker for our circadian rhythms lives. And as you see, these decrease with age and decrease even more in dementia. So this might be one mechanism. Another mechanism is reduced daytime activity and more napping. So these are actigraphy data from my laboratory. We have a demented patient and a non-demented patient. You're looking at midnight to midnight of day 1 and midnight to midnight of day 2 in both of these. And you see in the demented patient, there's lots of activity. There's hardly any sleep at all. This line, the thin line, is where awake was scored, and the thick line is where sleep was scored. So there's almost no sleep here. Whereas you see a more normal type sleep in the non-demented. So many awakenings, but at least they're getting some sleep. And this is very common in a demented nursing home patient. There's also, and these data again are in the nursing home, looking at people with severe dementia and mild to moderate dementia. And what we found is that they were never asleep for a full hour. This is the 60 minutes of any given hour. This is the 24 hours of a day. And if they were asleep for a full hour, the dot would be up here. They're never asleep for a full hour, and they're never awake for a full hour throughout the 24 hours. There's constant awakenings. The severely demented are sleepier than the mild to moderate, but they all have disturbed sleep. And the times of greatest alertness: breakfast, lunch, and dinner. But even then, some of the time, they're falling asleep. So the other next mechanism is reduced exposure to bright light. Patients in nursing homes and many in the community as well do not get much bright light exposure. And as I mentioned earlier, bright light is the strongest cue that our body has to know when to wake up, when to go to sleep, and to get good, strong rhythms. I'm a photographer, and people look at this slide and go, why didn't you lighten that up? That's such a dark picture. And I tell them that's the whole point. This was in the nursing home in San Diego, where we get a lot of sun. It's 2:20 almost in the afternoon, and these patients in the nursing home are sitting in the dark, and you can see 2 of them are sound asleep. And that is very common behavior. The amount of light that these patients are getting is very low. This is taken off the actographs, actually, the older actolooms where we recorded light levels. We would have liked to see at least 1,000 lux. And you can see throughout 3 days, not once does the light level reach 1,000 lux. In this individual, there are a couple of places where we reach 1,000 lux, but look at night. There's too much light during the night. They're not getting enough darkness at night. And as much as we need light during the day, we need darkness and light. And when we added all of this up, we found that the median daily light exposure in these demented nursing home patients was only 10 minutes a day. They are basically spending their entire life there in the dark. And it is one of the reasons why they have such disturbed sleep. And almost half of the residents were never exposed to any light above 1,000 lux. And what we found was that those patients who were exposed to higher average illumination levels during the day had more consolidated sleep at night, even when controlling for the amount of dementia. So bright light is very important for better sleep in any age group, but also in patients with dementia. There have been quite a few studies now looking at what happens when we increase light exposure in nursing home patients. And we know that it has a beneficial effect on sleep and on circadian rhythms in patients with dementia. And it results in less cognitive decline, less functional limitations, nighttime restlessness, nighttime agitation, and fewer depressive symptoms. So bringing light into the nursing home, whether with light boxes, this is a long time ago when the light boxes were quite large. That's how we did our study. But Us van Sameren in the Netherlands actually had lights installed into the common areas, and in that way was able to increase the amount of light exposure the patients were getting. So what about the relationship between circadian rhythms and dementia? These are two actigraph records where we're looking at the rhythms based on the activity. This individual had a nice strong rhythm. You can see lots of wake during the day, lots of activity during the day, less activity at night, and then during the day again. So it's a nice strong rhythm. This one, of course, has almost no rhythm. They're constantly waking up and falling asleep and waking up, and similar to the previous plot that I showed you. They are never fully awake during the day and for any given hour, and they're never fully asleep. And that's a more typical pattern of rhythms and sleep-wake in dementia patients. So we know what you're looking at here is younger adults in the blue, older adults in the red. We know that in dementia, you do get disrupted sleep-wake cycle. They're waking up much more often during the night. They're wandering and they're agitated. They sleep more during the day. And we do see changes to the suprachiasmatic nucleus. And all these things contribute to poor circadian rhythms as well. Circadian rhythm disturbances as the Alzheimer's progresses. You get in a prospective observational cohort study of 1,400 healthy community-based older adults. Circadian activity rhythms were recorded with actigraphy. These are all the different variables that they recorded. And what they found was that the risk of developing Alzheimer's dementia was increased with a lower amplitude, increased interdaily variability, which is how fragmented the sleep is, and decreased interdaily stability, which is the day-to-day robustness of the rhythm. Circadian amplitude, acrophase, and interdaily stability progressively decreased over time, and the interdaily variability increased. And the longitudinal change of global cognition positively correlated with the changes in amplitude and with the interdaily stability, and negatively correlated with the longitudinal change in interdaily variability. So what all this means is that there is a link between circadian dysregulation and Alzheimer's progression, implying either a bidirectional relationship or a shared underlying pathophysiological mechanisms. And perhaps if we could increase light exposure and strengthen the rhythms, that would have a positive effect on the dementia. This was, in fact, a study that we did looking at nursing home patients with severe Alzheimer's who had more disrupted rhythms than those with mild, moderate, or no Alzheimer's, and the weaker rhythms were associated with poorer executive functions over 5 years. That part is a soft study. Older, healthy women with decreased circadian activity, amplitude, and robustness, and who were phase delayed, had increased risk of developing dementia and MCI at 5-year follow-up. And in the study of older men, those with poor rhythms, lower amplitude, less robustness, had greater cognitive decline at a 4-year follow-up. So it's become very clear that poor circadian rhythms are associated with a greater risk of cognitive impairment and dementia. So to summarize, it is not aging per se that results in poor sleep, but rather all the things that go along with us, all the things that happen to us as we age that result in poor sleep. Although the need to sleep doesn't change, the ability to get the sleep that we need does change with age. Poor sleep in the older adult is often associated with medical and psychiatric illnesses, too many medications, changes in circadian rhythms, and primary sleep disorders. And no matter the age of the patient, sleep disorders should be treated if they're interfering with quality of life or if there's a medical risk associated with it. The relationship between sleep and circadian dysfunction and neurodegenerative processes are bidirectional. Sleep and circadian disruption increases the risk of both mild cognitive impairment and Alzheimer's disease. Sleep and circadian disruption are common in Alzheimer's, and behavior, physiological, and molecular markers of circadian systems function suggest that progressive deterioration of both sleep and the rhythmicity of the circadian rhythms occurs as the Alzheimer's disease progresses. Apnea increases the risk of both MCI and Alzheimer's, and treating the apnea may actually improve the progression, but we need more studies on that. And because late life sleep disturbances can be treated, interventions to improve sleep or maintain healthy sleep among these older adults may prevent or slow Alzheimer's disease to the extent that poor sleep promotes these problems. And with that, I will finish with my favorite quote: aging seems to be the only available way to live a long life. So I wish you all a long life filled with good sleep. Thank you, and I hope I've left enough time for questions.
Thank you so much, Dr. Ancoli Israel. This was excellent overview. We appreciate it. And we'll now turn over to the question and answer session. Thank you.